So what I would be personally talking in the next maybe half an hour, and I think we can utilize the next half an hour for discussions. So would be the rabies dilemmas and solutions. So as has been already mentioned by Dr. Anil as well as Dr. Meenakshi, that rabies is in fact among all the vaccine preventable disease, it is the only disease which is 100% fatal, which does not have a treatment, and which is almost 100% preventable. So almost I said, because that has a catch there. We'll come to it subsequently. So it's very important for us to understand how to prevent rabies. And as we all know, unfortunately, India accounts for 36% of rabies deaths that occur worldwide, and more than 20,000 people die due to rabies every year. On the positive note, Goa has been declared as the first state which is rabies free. That means for the last 3 years, Goa is not reporting any case of rabies. So I think that should be our aim too. In Kerala also, we should aim at getting a zero rabies death state. Andaman and Lakshadweep are traditionally no rabies states because their rabies have not been reported in these islands. But Goa is considered as the first state because it had rabies and now it doesn't have rabies. So that is the difference. So how do you prevent rabies? So we all know that you have a different, mainly it is by the three prongs, that is washing of the area, local wound care, as well as anti-rabies vaccine. These are the three pillars for prevention of rabies. Now let us see what each of these mean really in practical terms, in scientific terms. So when you come, and of course immunoglobulin. So when you say about the local wound care, it is naturally to decrease the viral load. So this is very, very important and something that we are always neglecting. So how do you give the local care? Anytime you have an exposure to the dog's saliva, anytime you have been exposed to a scratch by a rabid animal or a suspected animal bite or a scratch, immediately wash the area with soap and running water for at least 15 minutes. Why are you doing this? You are doing this so that the virus is washed away. The viral load is less. If the viral load is less, you would require less of antibodies to neutralize the virus that has entered your body. So this is very important. And whatever virus is left, you can again try to sterilize it with a disinfectant like an alcohol or an iodine solution. That is the betadine that you commonly say. This would be a virucidal agent. So whichever virus comes in contact with these medicinal products, that would also get neutralized. And those viruses which has not been washed away with your local care, which has not been neutralized by your antivirucidal agents, are the one you are going to tackle using a injection, which may be an anti-rabies vaccine or an anti-rabies immunoglobulin. So this step is very, very important. So now, why am I emphasizing on this step? You have to know that when the dog bites, we all know that the virus will enter the muscle, and in the muscle, the virus will replicate. From the muscle, it will go to the neuromuscular junction, and from the neuromuscular junction, it enters the spinal cord, and from the spinal cord, it reaches the brain. Till this time, the child is not going to manifest any symptom. And once it reaches the brain, it then again transmits downwards. That is, it is again going to come down. It is going to come to your cornea. It is come to your tears, come to your saliva. And that is the time when the patient really becomes symptomatic. By the time it reaches the brain, and by the time from the brain, it is again descending down. And throughout the whole path, it is important for you to understand that whatever you are doing, you're only trying to neutralize the virus at the level of the muscle. Once it has entered the nerves, once it has reached your spinal cord, there is absolutely nothing you can do. Your antibodies are not going to act, your immunoglobulins are not going to act, your vaccine is not going to act. So whatever we are doing it at the level of the muscle before the virus has entered the central nervous system through the peripheral nervous system. So we know that you have washed to remove the virus, and then you give the vaccine so that the vaccine will produce antibodies, and the antibodies will neutralize the virus. Now, what happens when you give the vaccine? Will it start producing the antibody immediately? No. When you're giving the vaccine would be first taken up by the dendritic cells, taken to the regional lymph node. On the way to the regional lymph node, it would be processing the antigen and expressing it on the surface, which would be recognized by the B lymphocytes, and they start initially producing IgM antibodies. Then since the vaccine is also recognized by the T lymphocytes, it will help the B lymphocyte migrate to the germinal center, cause a germinal center reaction, and start producing a large amount of IgG antibodies. But after some time, these plasma cells, which are producing the IgG antibodies, die off, whereas some of them will escape and hide in the bone marrow niches and produce a continuous amount of low level of IgG antibodies. Now, why did I say this part of the basic immunology? I said this part of the basic immunology for us to understand that the moment you give the vaccine, you don't get a protection. There is a lag period for the protection to happen. So once the vaccine is administered, it has to go to the regional lymph node, it has to stimulate the B cells and T cells, and only then you are going to get an antibody. So there is almost a close to minimum 7 days lag. Ideally, you would say 12 days or 14 days, but minimum 7 days lag. So it's only after the 7 days you're going to have a reasonable protection of antibody. But you should know that the incubation period of the rabies can be as short as 5 days or as long as months to years. So in order to protect you against during the time period when the vaccine is yet to produce antibodies, you are giving the immunoglobulin. I hope that is clear. That is, immunoglobulin is being administered so that you are protected against the virus immediately by neutralizing the virus which is present locally. Subsequently, if the virus is going to be persisting and producing an antibody, that would be neutralized by the antibody which your body is going to produce against the vaccine. So from there, we move on to again the graph highlighting the same thing that I said. You can see here post-exposure vaccination when you are giving, whatever schedules that you are following, whether intradermal, intramuscular, or the number of vaccine schedule, whatever be it, irrespective of the schedule, the first 7 days you don't have a reasonable antibody level. It's only after 7 days you're going to have a antibody level, and it is you're giving the immunoglobulin, whether it is a equine immunoglobulin or a human immunoglobulin, it is to protect you against the virus for this first 7 days. And now we know that there are 3 categories. Category 1 is touching or feeding the animal. Animal licks on an intact skin. So even if the dog is a rabid dog, but it has only licked you and there are no abrasions in your skin, that it is considered as no exposure. All you need to do is wash your exposed surface. Nothing else is needed. But if the animal has nibbled an uncovered skin, that means it has used its teeth. Nibbling means what your rats normally do. So if it has nibbled your skin, or if it has produced a minor scratch or abrasion without even bleeding, that is taken as an exposure, and that is a category 2 bite. And category 2 bite would require a wound washing as well as immediate vaccination. You don't require any immunoglobulin here. So category 2 is a bite exposure where there is no blood. There is not even a drop of blood there. There are no transdermal intrusions. It is only above the dermis. Category 3 is single or multiple transdermal bites or scratches, contamination of the mucous membrane, or broken skin with saliva from animal licks, exposure due to direct contact with bats. Now, this is not really taken as an exposure as far as India is considered because we do not have bat rabies. So we need to be bothered about the other things. That means, so this is one thing I want to highlight. It is not only the depth of the wound. It is not the size of the wound that decides whether it is a category 3 wound or not. It is the depth of the wound that decides whether it is category 3 or not. So even if you have a very tiny scratch, even if you have a very tiny bite, but you find that it has gone through the dermis, you can see a blood mark there, it becomes a category 3 bite. So that is very important for you to know. Because once you have gone beyond the dermis, the virus has entered your muscular plane, the virus would definitely reach the nervous and can reach the nerve at any time. So you want to neutralize it before it reaches the nerves. And that is why any transdermal bite requires an immunoglobulin. So I hope it is clear. It is not the length of the wound that decides whether it is category 3. It is the depth of the wound that decides whether it is category 3. And also we need to know that even if you had a previous scratch and the dog did not bite you, but the saliva has been put there, the dog licked you, it is a category 3 bite. If by any chance it's a pet dog, you have an exposure on your mucous membrane, it is a category 3 bite, which requires both immunoglobulin as well as vaccine. So now, what if your patient is immunosuppressed? Because you come across children who may be on nephrotic syndrome prophylaxis, or they may be having other illnesses because of which they are immunosuppressed. What is the difference here? Here the difference is both category 2 and category 3, the treatment is same. So even if the patient is having a category 2 exposure, if the patient is immunosuppressed, he should be offered rabies immunoglobulin. So we all know about the exposures. The IM schedule, usually you have the 0, 3, 7, 14 and 28. You are giving a single dose schedule. And most of the places now we are using the intradermal schedule, where you have 2 doses being given on 0, 3, 7 and 28. So now why did I color up the 28? I colored up the 28 because we still follow the same regimen. But according to WHO, this day 28 dose is not mandatory. What is most important is the 037 dose or 03714 dose. So it is the initial doses that is more mandatory. But we will still follow the day 28 dose because the DGCI, the Drug Control of India, has not yet approved the WHO schedule. So we are expected to give a dose on day 28 also. So I hope the schedule is clear. So now let us see some of the common situations that we may encounter. So you have a vaccinated pet at home. Is it enough to protect my baby? So many people believe my dog is vaccinated. So even if it bites my child is protected. I do not need to do anything. But you need to know that a dog is considered immune only if the current age of the dog is 1 year. That means the dog's immune system is robust to have responded to the vaccine. The first dose of the vaccine was given at an age more than 3 months. 2 doses were given at 6 months apart, and the dog is also getting yearly vaccination, and the vaccine used is of good quality. So even though these are the recommendation, but in practice, I would say whenever you have an exposure, a category 2 or 3 exposure to a dog bite, irrespective of whether it is a pet dog or a stray dog, it is always better to go for a post-exposure prophylaxis because there are conditional recommendations. Now comes to another option. If you have a pet at home, or many times you would see that children who enjoy interacting with pets, they would come to you repeatedly with bite marks, scratch marks and all. So every time they come, are you justified in going on giving them vaccines? So for these children who are recurrent exposure, so someone who is involved in veterinary care, definitely you can take your pre-exposure prophylaxis. Pre-exposure prophylaxis, here again, you can use intradermal schedule or intramuscular schedule. So intradermal schedule, it is 2 doses on 0, 7 and 28. So you're giving 2 doses if intradermal on 0, 7, that is 1 week and 1 month later, that is 3 doses. If it is IM, it is single dose on 0, 7 and 28. So does that mean that if I take a pre-exposure prophylaxis or a post-exposure prophylaxis, I am protected for life? Anytime I get any bite, I don't have to take anything? No, you are not protected for life. Anyone who has completed a pre-exposure prophylaxis or a post-exposure prophylaxis is protected only for the next 3 months. After 3 months, the antibody titer is going to come down. So after 3 months, if you have a rabbit bite re-exposure, you need to take a booster. And here the booster is 2 doses, 1 on the day of bite and 1 on the 3rd day. So I hope that is clear. If you have taken a complete pre or post-exposure prophylaxis and you have a re-exposure after 3 months of completion of the prophylaxis, you need to take 2 doses on day 0 and day 3. And here the day 0 and day 3 are single dose, whether it is intradermal or intramuscular. So why do we say that after 3 months, for first 3 months you are having re-exposure, you don't require to take any antibody, and after 3 months if you have re-exposure, you have to take the antibody and you have to take the vaccine, but you don't require immunoglobulin? I hope that part is clear. If you are ever vaccinated with a pre-exposure prophylaxis or a post-exposure prophylaxis, in future, if you have a rabid dog exposure, you need to take the vaccine boosters, but you do not need immunoglobulin. Why do we say so? As you can see here, once the vaccine is given, your antibody titers go up very high, and after 3 months, it starts coming down. And that is why they say that after 3 months, if there is a re-exposure, you take a booster. And if you take a booster, the titer just shoots up, and there is no lag period. So for somebody who's taking a 0-3 dose, immunoglobulin should not be given irrespective of the category of bite. So immunoglobulin is given for only a naive patient who has never taken any vaccines before and who has a category 3 exposure. Any completed exposure where you are going to use only 0 and 3 doses, it does not have an immunoglobulin there. Now, moving on to next situation. A history of category 3 dog bite to a patient 15 days back. So somebody had a dog bite. It was category 3. He did not visit any hospital. He did not show anybody. But just 2 weeks later, somebody said, oh, that dog had died. The dog was a rabid dog. The dog died 1 week back. Now what do? You can say that it is almost 15 days since the patient has got a exposure and the patient is completely normal, so you can leave him alone? Or do you want to give vaccine alone? Or do you want to give both vaccine as well as immunoglobulin? So now the problem here is you should know that the incubation period of rabies is classically 2 to 3 months. It can be as short as 4 days and as long as 6 years. Commonly 2 years na parana, but it can go up to 6 years. And usually the symptoms starts with non-specific symptoms like fever, headache, and death usually occurs 2 to 10 days after onset of symptoms. Classically, the rabies progresses through 5 stages. The first stage is the incubation period, which I already mentioned, can vary from 5 days to more than 2 years. Then you have the prodromal phase where you have very non-specific symptoms like lethargy or headache, which may last for 0 to 10 days. And then you have the acute neurological period where you are going to have manifestations of furious rabies, or you have the dumb rabies, neurological manifestation for 2 to 7 days. And then the patient slips into coma and finally death happens. So commonly, we need to know that in a furious rabies is the one, 80% of them are going to present you with furious rabies. That is the one who would be complaining of hydrophobia, aerophobia, restlessness they would be having. Whereas 20% would manifest as paralytic rabies. There is no hydrophobia. There is only muscle weakness, loss of sensation, and paralysis. In both these cases, what happens is usually the death happens within 10 days of onset of symptoms. So that is the lifespan of a patient once he starts developing the symptoms of rabies. And in case of paralytic rabies, the duration of lifespan may be slightly more than in case of a furious rabies. Now then, what was the thing that we learned about the 10-day interval? So we have to remember the 10-day interval is for the dog, not for the child. When you are starting a vaccination schedule, you are asked to monitor the dog or the cat for the next 10 days and see that if they are showing any symptoms of rabies. So why do you say 10 days? That is because a symptomatic infective dog is unlikely to survive beyond 10 days. So if the dog is symptomatic and the dog has bitten you and the dog has rabies, the dog will most probably die within 10 days. That is why you say observe the dog for 10 days. The median survival time is usually 4 days. But we should also know that an apparently normal looking dog may transmit rabies because the virus may be excreted through the saliva 3 days prior to the symptom onset. There has been very rare reports of even 14 days prior to symptom onset, but usually it is 3 days, and that is why you are given a time interval of 10 days, and the 10-day interval is for monitoring the dog. Now, so what is the conclusion for our patient? Irrespective of the days passed since the dog bite, vaccinate the patient as per the class of wound. So the patient had an exposure 1 month back. The patient comes to you now. It was a class 3 bite. You give both immunoglobulin as well as vaccine. It was a class 2 exposure. You give only vaccine. So it is depending on the exposure that you had. Now, what to do if a rat bites? So that's one of the commonest bites that you encounter nowadays. So here you should know that the usual recommendation is wash the site, offer tetanus if indicated, and it is not necessary to take a post-exposure prophylaxis if the bite is by a house rats. Now, what does this recommendation mean? Does that it means that the mice does not transmit rabies? No. The fact is that even your house mouse or rat can transmit rabies, but it is assumed that because of the small size, if it is bitten by a rabid dog or a rabid cat, it will not survive. That is the assumption. The assumption is that a rat which has been bitten by a rabid dog or cat will not survive the bite to bite you subsequently. So that is the reason why they say that if you are bitten by a rat inside your house, you don't have to take a post-exposure prophylaxis. At the same time, it is recommended that wild rats, rodents, bandicoots, that is the huge rats that you will find in your railway stations and some of the public places you do find because of the way we dispose our waste material. They are everywhere nowadays, and all those exposure require an anti-rabies vaccine. So again, telling you the reason why house bite, where the in-house rat bite do not require anti-rabies, the reason I've already said. But squirrels and rabbits are also expected not to transmit rabies for the same reason. But in our hospital, we have had a confirmed case of rabies and rabies death due to a squirrel bite. So whenever you have a confusion, err on the side of administering the vaccine rather than erring on the side of not administering the vaccine. Now, what about drinking rabid cow's milk? This is also very common because what happens, they say, is that the moment the owner finds that the cow is showing features of rabies, they immediately milk the cow and donate the cow's milk to the temple. And then from the temple, the devotees take the raw milk as an offering, and then everybody is scared that will they get the rabies. The fact remains that, in fact, in scientific literature, no prophylaxis is needed because there is no report of rabies being transmitted by drinking milk. And especially boiled milk, you don't have to be scared at all. And I would say that it is not recommended. So don't, please, if you have a cow at home and it shows features of rabies, please don't milk it and distribute among your neighbors. Now, what are the signs of rabies in a dog? Biting without any provocation, eating abnormal items, running for no apparent reason, a change in sound of barking, hoarse barking, growling, inability to make a sound, excessive salivation, or foaming at the angles of mouth are all features of rabies in a dog. So that is important for us to know that when to suspect. When you say observe the dog for the next 10 days. So when you're observing the dog for the next 10 days, these are the features that you should be looking for in the dog. I've mostly mentioned dog because dog is the commonest reservoir from where rabies is transmitted to humans. Now, what about those disfiguring wounds that come to you? Can it be sutured? The recommendation is avoid. Why do you say that avoid suturing a rabid wound? That is because when you are bitten by a rabid dog, you have a lacerated wound there. The wound is fully contaminated with the saliva of the rabies, of the rabid dog. That is, the rabies virus is there. And there, when you go for a suturing, you are creating an artificial wound there. And through the wound, the rabies virus will enter the tissues deeper to it. So you are giving the virus to enter your body a new route. So that is why they say that do not suture as far as possible. But some disfiguring wounds will require a suturing. In that case, first give the rabies immunoglobulin. And only after giving rabies immunoglobulin should you suture. Under no circumstances should you suture without giving a rabies immunoglobulin. And here again, put loose sutures allowing bleeding and drainage. And secondary suture may be done for wound closure subsequently. Now, this we all know. If you have a wound like this, you would not have no doubt that this is a patient who would require both immunoglobulin and vaccine. What about this? If you have a scratch mark, and cats are notorious to scratch, do you require really an immunoglobulin for a bite as small as this? Yes, the answer is, repeating again, any small scratches where the blood can be seen, that means the virus has entered beyond your dermis. It's a transdermal scratch or bite. So it requires an immunoglobulin. So the reason, again, I'm telling that we all know, as I already mentioned, that once you give the vaccine will produce antibodies only after the day 7. And when you give the immunoglobulin, you can see immediately the antibody levels come up and it neutralizes. It is again another important thing that I want to tell you, that the immunoglobulin has to be administered at the site of injury. There is no role for giving immunoglobulin away from the site of injury. Please do not mix vaccine and immunoglobulin in the same syringe. Please do not administer vaccine and immunoglobulin on the same limb. Immunoglobulin, as far as possible, has a role only locally. Nowadays, when we say that equine immunoglobulin, rabies can be given 40 IU per kg, inoculate as much as possible locally, and rest you can give intramuscularly. That is what our previous guideline says. But you should know that the rest inoculated intramuscularly has very limited role or no role. Whatever role an immunoglobulin has is mainly at the site of injury, at the site of inoculation. So that is very important. In fact, the latest WHO guideline says that you need to inoculate what is possible at the site of injury. And if you have a dose left, imagine you have a 10 kg child, you are going to give 40 IU per kg, 400 IU. The child had only a small scratch. You were able to give only 100 IU for that child. Less 300 IU is left. So usually that 300 IU we go and give intramuscularly, and now the WHO says you don't have to waste it like that. Just keep it aside and you can give it to the next child who needs it. But if you are doing like that, then you have to take the immunoglobulin in separate syringes. You cannot use the same syringe for multiple patients. And the separate syringe, once you have fractionated it, has to be used within 4 to 6 hours. That is within one immunization session. After immunization session, never keep the immunoglobulin to be used for a next patient. So how long does the immunoglobulin protect? So we already said it is mainly intended to protect for the first 1 week, but the half-life is 3 to 4 weeks. So it would definitely have a role for the next 2 to 3 weeks also. Now, what about the doctor who has come in contact with a rabies patient? Does he require a post-exposure prophylaxis? We should know that human-to-human transmission has not been reported. Urine, blood, and feces are considered non-infectious, even though the virus has been seen in the urine. Virus is present in abundance in sperm and vaginal secretion, and all cases of human rabies that has occurred are occurred through organ transplant. So that is very important. So whenever you have a neurological cause, unknown cause, if rabies is a suspicion, you should not be taking the cornea for transplantation because you may be transmitting the rabies to another person. So rabies infection is a contraindication for organ transplantation. Then doctors who are working in the ER or in the ICU, where you intubate and you suction, connect to the ventilator, those kind of procedures where aerosolization and salivary splashing to your mucous membrane and ice can happen, are recommended to receive a post-exposure prophylaxis. Now coming to next scenario, that is, you thought that this wound, it was a small scratch wound that he requires only vaccine, and you started the vaccination. But now when they came for day 3, you realize that no, this was a class 3 wound. I should have given a rabies immunoglobulin. It may be a patient who started the vaccination at some other center and has now come to you, and you recognize that this is a class 3 wound. It may be a patient who could not afford the rabies immunoglobulin on day 1, and now they are willing to shell out the money. All these situations where you have started the vaccination and now the patient comes later, can you offer the rabies immunoglobulin? So here the answer is that after starting the vaccination, immunoglobulin can be offered up to 1 week. So imagine it is a class 3 bite. The patient had received only the vaccine and the patient comes to you after day 7. There is no role for immunoglobulin. There only you have to continue with the vaccination schedule. Only before day 7 of initiation of the vaccine, if they come, you need to give the immunoglobulin. So this, when I discuss this, I also want to emphasize that wherever you are working, imagine a child who is bitten by a rabid dog is born, and you do not have an immunoglobulin in your center. What should you do? Refer the child immediately? I would say that when you see a child, thoroughly wash the wound site, clean the wound site with spirit or with alcohol or with your betadine, and then give the vaccine and refer to the next center from where they can get the rabies immunoglobulin, because cleaning and administration of vaccine is important. Earlier the vaccine is administered, earlier your body will produce the antibody, and earlier you will have a protective antibody response. So irrespective of the patient whether they can afford an immunoglobulin or not, the vaccine and wound cleaning has to be offered, and every class 3 bite should be ensured that they receive also the immunoglobulin. Now, this was a condition that we faced very recently in a private hospital, because this happens when you have pets at home. The child had a class 2 exposure, so the pediatrician had started the post exposure prophylaxis. And on day 10, the child is now brought with a class 3 exposure. Now, what do you do? So, you have already started the schedule, you have already given 037, and now on day 10, she has come with a class 3 exposure. So, here the guideline is you just continue with the vaccination schedule, because here the child would have already had the antibodies, and here there is no role for giving immunoglobulin. Then this was one of our cases. It was a 3-year-old child who had a very small 0.5 centimeter bite on the leg, for which she had received anti-rabies vaccine intradermally. So she had taken 0, 3, 7 and 14. So next was due, not 14, 0, 3, 7. So the next due was on day 28. But on day 25, she presented with ataxia. So we initially thought that it was probably a vaccine-induced demyelination or something, and the child was admitted. But unfortunately, the child rapidly deteriorated, and within 24 hours of admission, the child required intubation. And post intubation, when we sent the corneal imprints as well as saliva, both came positive for rabies PCR. So now we have, so this was a confirmed case of rabies in a child. So where did we go wrong? So this was a child who had a small bite, and she had received the anti-rabies prophylaxis, and still the child developed rabies. So we should know that most of the post-exposure prophylaxis cases happen before the day 28, just like the one I described. And that is also one of the reasons why WHO has taken away the day 28 dose, because those who fail post-exposure prophylaxis, the failure is happening before the day 28. So the initial management is of utmost importance. And the next is the reason why this child developed the rabies. It could be two reasons. One is, even though the bite was only 0.5 centimeter, it was a category 3 bite, because still there was a scar. So a scar will happen only when it becomes a transdermal bite, and the child was not offered an immunoglobulin. The next reason could be a faulty administration. What do you mean by a faulty administration? A rabies vaccine which is given in a gluteal region is invalid. So if the patient has received the vaccine in the gluteal region, it is as good as not getting vaccinated, because the gluteal region has a lot of fat. So instead of your vaccine become intramuscular, it may become subcutaneous, and where the vaccine efficacy is very low. And when you're giving an intradermal vaccine, if the vaccine does not produce a wheal, as shown in the picture, if you don't have that puree orange coming up, that means you have gone subcutaneous. The vaccine will not be effective. So all those who are listening to me and all of those who practically give the vaccine, it may happen that when you administer, you are not seeing the wheal. Don't hesitate. At that moment itself, you can give an extra dose producing a wheal. So intradermal route is highly efficacious. In fact, there are multiple studies which have shown that the intradermal route and the intradermal schedule of vaccination produces, in fact, a higher antibody titer, especially because you're giving 2 doses there. So it is not the vaccine route that is making a problem here. It is not the vaccine quality that is making the problem here. It is the way you administer the vaccine. That is, instead of becoming intradermal, if it becomes subcutaneous, your vaccine becomes ineffective. So that is Very, very important to know, and you should repeat your vaccine then and there. Then another thing before we move on to the vaccine failure, I would like to say is that you should also know that if the bite has happened directly on top of a nerve, the virus has directly entered the nerve, then even when you give a complete post-exposure prophylaxis, vaccination failure can happen. But this is a very, very rare situation. So in US, the CDC says that they have zero post-exposure prophylaxis failure. So that also tells us that if you do the things properly, post-exposure prophylaxis is a very exceptional role, close to 100%, definitely an appropriate post-exposure prophylaxis prevents rabies. So that's a very important point for us to remember. Now coming to the immunoglobulin. So immunoglobulin, now you have three types. You have the equine rabies immunoglobulin that is commonly available. Then you have the human rabies immunoglobulin that most of us were giving in the private sector. And now you have a newer product that is the rabies monoclonal antibodies. So regarding the equine rabies immunoglobulin, you should know that these are produced from the host serum. So naturally, they are very less in number, very difficult to procure. And that is the reason why the WHO has come that infiltrate it locally and what is left can be given to the next child because of the scarcity it is. And the dose is 40 IU per kg. And here again, I repeat, infiltrate as much as possible locally. The giving the IM dose away from the site of bite does not have much role. Main problem with equine and rabies immunoglobulin is the risk of reaction. But most of the immunoglobulins are highly purified, so the chance of reaction is less. WHO does not recommend a skin test, but the manufacturing unit, usually when you buy it, the leaflet will say that you do a skin test. But remember, the skin test only does not always predict reaction. And even if there is a reaction, you are expected to give the immunoglobulin, but under proper anaphylaxis prophylaxis, and also in a facility where anaphylaxis can be managed. Then if it is human rabies immunoglobulin, the chance of reaction is less, but it has a shorter half-life, it is more costly, and the dose is 20 IU per kg. Rabies monoclonal antibody, it is now available two forms. You have the Rabies Shield as well as the Twin Rab. Both have a different dose. The main advantages of monoclonal antibody is that it is a newer moiety. It is produced in the family, in the factory made, so large quantity can be produced. So unlike the equine rabies immunoglobulin or human rabies immunoglobulin, the production is much easier for rabies immunoglobulin, monoclonal antibodies. And monoclonal antibody, there is no batch to batch variability. So you have the same concentration getting in all your batches. So when you look at the comparison with human rabies immunoglobulin and monoclonal antibodies, it has been found that the anti-rabies antibody is comparable on day 3 and day 7. And also it has been found that it produces comparable rabies virus neutralizing antibodies. And the proportion of participants with adverse events were comparable. So when you compare human rabies immunoglobulin and rabies monoclonal antibodies, you can select either. You don't have to be scared about the newer moiety. It has been also found to be as efficacious as the older ones that we were using. So now what are the take-home messages? Rabies is 100% fatal. Appropriate post-exposure prophylaxis is close to 100% efficacious. It is the depth of the bite or the scratch that decides the class and not the size of the site of the wound. Immunoglobulins and vaccines are effective only for neutralization of the virus before it enters the nerve. Once it enters the nerve, your immunoglobulin and vaccines are not going to be effective. So start your prophylaxis as early as possible. The immunoglobulins are for protection of the first 7 days when your vaccine is yet to produce the antibody. So all class 3 wounds should be offered immunoglobulin. Newer monoclonal antibodies are found to be as efficacious as the older rabies immunoglobulins. Thank you.
Yeah, what is the cost of this monoclonal antibodies?
In fact, monoclonal antibody is slightly cheaper than the human rabies immunoglobulin. So it would be around 2005. The human rabies immunoglobulin is usually 2500. The other one would be 1700 range.
the shelf life.
It has a
Human
reasonable
is
shelf life. It has a reasonable shelf life.
so
Is it available here? Is it available here?
Yes, yes, it is available. It is
So
available at.
we can recommend the human this
Yes,
monoclonal antibody.
we can recommend monoclonal antibody. It is locally available at our hospital, in our immunization clinic also it is available. The patient has to pay for it.
Okay.
So it is available.
Okay, thank you.
Will immunoglobulin interfere with COVID vaccine or any other? That is one question.
Okay. So now that's a very good question, in fact. So immunoglobulin per se would, COVID vaccine that we right now have is not considered as a live vaccine. So immunoglobulin interference is only for live vaccines and only if the vaccine specific antibodies are there. So especially when you're using a rabies monoclonal antibody, there is absolutely no doubt there would not be any interference. And even otherwise also, as I already said, COVID vaccines are not live vaccines, so there is no interference. You can go ahead and take both.
Next is, ma'am, what about the conjunctival lacerations or aberration? Is it included in category 3? It's already, I think.
Yes, it is included in the category 3. Only here the problem is you cannot give the local infiltration. It's not possible. It is definitely category 3.
Ma'am, my question was that, ma'am, I had cases where this fingers are taken off by the dogs and exposing the bony parts. I was asking, ma'am, is that ERIG administration to the level of subcutaneous tissue is enough for this case, where there is a high chance of direct infiltration to the nerve endings?
And anyway, there is always a chance of direct infiltration, but still what we can give is only through the around the bone, right? So you would give it intradermally as well as subcutaneously. So whatever is possible, how much you can give locally, infiltrate locally.
Okay, ma'am. Thank you.
Okay.
Is IM and ID regimens interchangeable?
I thought that question would come. So the answer is no, because there are no, in fact, there are no studies. So that's scientifically thinking, you would say that there should not be a difference. You should be able to do. But unfortunately, we don't have studies where they have given one dose IM and then gone to ID, or they are given an ID dose and then gone to IM. So as long as there are no studies, it will be difficult for us to recommend. So if you continue with one schedule, it is always better to complete with the same schedule. Scientifically,
if there is a break, if there is a break in, for example, if the patient has taken 2 doses of IDRV and he's not in a position to take another in IDRV, maybe he might transfer somewhere place and there is it's not available. Then can we start? He has to restart everything.
No. As if, for example, the patient has taken day 0. The patient did not come on day 3. The patient instead came on day 10. So if the patient has come on day 10, consider it as day 3. And then you give the day 3 vaccine there. 4 days later, you will give the day 7 vaccine. However late the patient comes, you just need to continue the vaccine from there. So just shift the schedule there. But day 3, vanilla. He's coming on day 7. So give the day 3 vaccine on day 7. And the day 7 vaccine will reach day 10.
So if the IDRV is not available, for example, can we shift to IM?
Okay, that also, okay, that I didn't answer. So imagine, because the private hospitals, they're not giving intradermal. So the patient has shifted somewhere and then they want to continue the vaccination schedule. It may be patient going out of the state also. In that conditions, definitely you can go ahead and continue with your IM schedule. You have to take the vaccine, that is more. Restarting is not needed. I think that was the question. That is, you started with an intradermal schedule and then you're shifting to IM schedule. Should I restart the whole schedule? Not exactly.
So many have the same question because
both IM and ID preparations are same.
Both IM and ID preparations are same, but everything that is given IM cannot be given ID. Everything that is given intradermal can be given IM. So that is the difference. For example, human diploid cell vaccine, it cannot be given. It is not recommended. It is not permitted to be given intradermal. So otherwise, if the same vaccine you're giving intradermal, it's the same vaccine that you're going to give IM also.
Madam, may I add something to the question?
Can be given intramuscularly, but all anti-rabies vaccines which are given intramuscularly are not licensed for intradermal.
Okay. Dr.
Thank you,
Salim
madam.
has started something.
Yeah, I was just asking, madam. Already, madam has answered that we can shift to IM in case of if it is not possible to continue with ID regimen. So I was asking whether somebody has completed 0, 3, and 7, and if we have to change to IM regimen, should we add the 5th dose like 14 and 28, or just what should be the schedule?
What should be? The problem here is that we cannot really say the schedule because, as I already said, there are no studies recommending a shifting from intradermal to intramuscular or vice versa. So, if a patient comes to you, our primary aim is to ensure that they continue the schedule with the schedule that they have started. So it should not, if what we are now discussing is an exceptional state where you want the baby to receive a vaccine. That is why you said you move on. If you are not possible to give ID, then go with IM. But I would say always try to continue with the same schedule that you have started. And if you are moving on to IM, naturally day 14 and day 28, both will be needed.
One
Okay,
pregnant
thank
lady. One pregnant had exposure in the last week of her EDC, and by a street cat, and she didn't take any treatment and did no vaccine, nothing. After 3-4 days, she is coming with labor pain, and unfortunately, she need cesarean section. What about her vaccination, and what about the baby? Baby need any vaccination?
No, baby will not need a vaccination here because we need to know that this even if the patient is exposed to a rabies virus, that means if the cat scratch was a rabid cat scratch also, she is going to be infective only when it already reaches the brain and then comes down to the saliva and the cornea and all those areas. But during the incubation period, you are not infective. So the rabies virus is not causing a viremia. It is not a virus that causes viremia and causes the disease. It is mainly through the nerves it is going to go. It's a local transmission happening there. But here, if the mother is getting, the baby does not need any prophylaxis, but the mother can be offered prophylaxis. However late she is coming, she can be offered prophylaxis.
What about the vagina secretions and all? That may be infective.
No. At that time, when we are handling the patient, it's highly unlikely that the patient is infected because the patient is asymptomatic, right?
Asymptomatic.
Asymptomatic. So if the patient is asymptomatic, her vagina will not contain the virus. Only after the patient
becomes
symptomatic,
vagina will be contained.
Definitely. If she's symptomatic, that means if she's symptomatic with rabies, definitely vaginal secretions will have rabies virus. And you are expected to take post-exposure prophylaxis.
Without the symptoms also, the virus will be there in the secretions.
Without symptoms, the chance of virus being there in the secretions is very, very less. Maybe 3 days. That is what I already said. Before onset of symptoms, for 3 days, you may have virus. But it's highly unlikely.
But what about breast milk? Breast milk, the child?
No, if the patient is not symptomatic, the breast milk is not going to contain the rabies virus. Because the virus from the local area, it spreads through the nervous tissue only. So it is not going to come and secrete it to so once the patient is symptomatic, breast milk virus, we haven't checked whether it is excreted there. It may be, we do not know. But only after the patient has become symptomatic, not before that.
Actually, patient അന്ന് കാനഡയിൽ പോകാനായിട്ട് എല്ലാം റെഡി ആയിരിക്കുമ്പോൾ അന്ന് തന്നെ വീട്ടിലെ പെറ്റ് ആയിട്ടുള്ള ഡോഗ് കയ്യില് സ്ക്രാച്ച് ചെയ്തു. അപ്പൊ അവരുടെ ക്വസ്റ്റ്യൻ ഇതായിരുന്നു, വാക്സിൻ ഇന്ന് എടുക്കണോ? വീട്ടിലുള്ള ഡോഗ് ആയത് കാരണം വാക്സിൻ എടുക്കേണ്ട ആവശ്യമുണ്ടോ? അത് മാത്രമല്ല, ഇപ്പം വാക്സിൻ ഫസ്റ്റ് ഡോസ് ഇവിടെ നിന്ന് എടുത്താൽ ഇന്ന് അവര് പോവാൻ നിൽക്കുവാണ്. അപ്പോ ബാക്കിയുള്ള ഷെഡ്യൂൾ എങ്ങനെയായിരിക്കും? അവിടെ പോയി കണ്ടിന്യൂ ചെയ്യാൻ പറ്റുമോ? അങ്ങനെയായിരുന്നു ചോദിച്ചത്.
Absolutely no problem. They can take the vaccine now and they can continue the schedule at wherever they are going. Absolutely no doubt about that. But wherever you go, you have the anti-rabies vaccines are available and you can continue with the schedule. Only thing is you need to have, and most of the brands that are available in India are available outside also. And brands may change also. All the brands you cannot say, depends on the country where you're going to. And definitely have the vaccination certificate. The dose have the certificate with you and go with that certificate. You can continue vaccine. എടുത്തിട്ട് പോവാം.
Thank
I think the question is there. I think it's from Dr. Akshay. It's written that in case of other animal bites like monkey or any other animal where we don't know the rabies status of the animal, should we give the anti-rabies vaccination schedule? I think this is the question you are trying to ask. Is it so?
Yes,
Yes. Okay. But if that is the question, the answer is we are never looking at the rabies status of the animal to decide whether we want to get the vaccine. Any animal bite exposure, you are expected to give anti-rabies vaccine according to the category. Because we already said no, animal can become symptomatic after the bite also. Maybe you were the first victim of this thing. So don't bother about the observing the animal. Just go ahead and give the anti-rabies vaccine.
thank you, ma'am. Madam, human bite? Madam, human bite?
Human bite, no. Means I think you are trying to ask me if the patient is having rabies and the patient bites you. If the question is that, then I would say go ahead and take the vaccine. But it's very unlikely. We haven't come across.
But it can spread through the vagina secretions and saliva and all.
Yes. Definitely, yes. So know this thing. If the patient has bitten you, and I already said that when you're doing a suction to the patient, when you're intubating the patient, your mucosal exposure is there, and you are expected to take the post-exposure prophylaxis. That applies to vaginal secretion. That
After conducting delivery, also better the doctor.
Yeah, it's better to take. It's better to take. Otherwise, also I feel it is better to take a pre-exposure prophylaxis, because anytime you have an exposure, you need to take only 0.3. You don't have to take the immunoglobulin.
I am Dr. Sanjay Swani. My question is, whenever we are having bite in pregnant woman, which is the safe time, or all the times we can, from first trimester to last trimester, we can give the vaccine?
Yes, irrespective of the trimester, definitely, because patient's life is more important. The trimester doesn't come into play at all. Whatever be it, you can give.
Okay. So no teratogenic effect.
No teratogenic effect has been reported, and we don't have to think about that, because unless the mother survives, how do you get a baby to see whether the patient is having a teratogenic effect? So no confusions there. Mother is precious.
Thank you, madam.
So I am going ahead with some questions.
It is from Odisha. I'm Dr. Rajesh speaking. Can I put one question, madam?
Yeah, definitely. Go ahead.
Madam, recently one person who is having the COVID Rabid, and he was smoking, and that cigarette is shared with another person. Shall he take any vaccination or not?
If that patient subsequently died of rabies, then you would definitely require it.
Hello?
If the patient was rabies, yeah. If you have shared a cigarette with a patient who was having rabies, you need to take an anti-rabies vaccine. If it was just a person who had an exposure to a suspected rabid animal and he never developed the rabies, you don't have to take the vaccine.
Thank you, madam.
I hope it's clear, right?
Yes, madam.
Okay.
Madam, I'm just combining some questions that I am seeing in chat. They wanted to know about squirrel bites, rat bite, then bird's claw marks, boar attack with its tusk. So these are some specific animals where if there is any need of rabies vaccination, they have asked via chat. Squirrel, rat, then bird claws, and boar attack, then duck and hen.
Okay. Basically, okay. I think I'll just try to make it smaller. That is, one thing is a squirrel bite. Somebody has asked that whether the rabies was confirmed. Yes, it was confirmed, and it was also published in the Indian Pediatric Journal also, that particular case, because it was a confirmed squirrel bite. The child died of rabies. The child had symptoms of rabies, and the rabies PCR was positive in his CSF as well as saliva. So that was a confirmed case. So squirrel can transmit rabies, even though they say that it will not. Then regarding rat bite, if you need vaccination or not. If you have had a rat bite in a public place, please go ahead without any confusion to get the vaccine, because the most of the time the bite you're going to have is by the bandicoots. Bandicoots means the big rats, the bigger ones, and they are rabid and they can transmit rabies. Now, what about the small mouse that you have at home? do you need an anti-rabies vaccine? According to the guidelines, anti-rabies vaccination is not recommended. All you need is a tetanus prophylaxis if the patient has not received tetanus. Wherever you are in doubt, go ahead and give anti-rabies vaccination. Wherever you are confirmed that it is not, and regarding the duck and hen, bats and your eagle, sometimes they ask, birds don't transmit rabies, so you don't have to be bothered about that. And bird bites or this thing, you claws, and then rabies is not needed. Anti-rabies is not needed.
I'm Dr. Raju speaking from Odisha. Okay. And we are giving in Odisha intradermal injection, Vaxirab. Okay. Can you switch to intramuscular?
No, that is what I said. As far as possible, you continue with your intradermal schedule itself. If it is not possible, only you move to intramuscular schedule, because there are no studies. WHO does not recommend shifting of schedules.
Okay, I'll read the question once again. Does re-exposure after 10 days require repeating the schedule, ma'am?
No. So that is, I said, if after 10 days, up to 3 months, if there is a re-exposure within 3 months of a complete pre or post-exposure prophylaxis, neither vaccine nor immunoglobulin is recommended. But if there is a re-exposure after 3 months,
will drops of immunoglobulin in the eye be useful in the laceration of cornea?
In fact, there is no, the recommendation itself says that administer immunoglobulin where feasible. So administering immunoglobulin in the eye when the corneal laceration is there will not be, is not really recommended. Whether the drops of immunoglobulin may be useful, thinking wise it looks useful, but whether it is damaging to the eyes, I do not know. So it is not recommended, in fact.
How will we give the immunoglobulin in case of conjunctival?
Yeah, here you can give only IM. You cannot give it in the local area.
India, Kerala scenario, what are the animals other than wild animals that which PEP, post-exposure, is recommended, indicated?
I didn't get that question.
Other than any wild animals, any domestic animals, if
every mammal can transmit rabies.
So for all animals, we need to expect.
Commonest is dog and everything can transmit, not birds.
Patient come with dog bite, they don't have the status of dog, whether rabid or not. In this scenario, what's your advice? Again, madam has made it clear already. My first patient as a house surgeon was a rabies patient, present vague stomachache for evaluation. Later at night showed symptoms of hydrophobia and then shifted to isolation room. All contacts were traced and sent for vaccination. Okay, that was a comment only.
Yeah, that's it.
If the patient refuses to take immunoglobulin, what should be done? Especially if the patient is a child and the parent refuses.
First of all, you have to get a proper counseling and get it documented that they are refusing, because this is in fact a child abuse happening there. That is another thing. The next is you should know that even if you do a thorough washing of the wound and you give the vaccine itself, it will protect to a great extent. Immunoglobulin is aimed to give you 100% protection, but the vaccine with thorough clearing of the local wound itself will be protective for a vast majority of the patient. But a class 3 wound where the patient refuses immunoglobulin has to be documented. Because I personally have seen 4 cases of immunoglobulin death, of rabies death in the last 7 years. And out of that, only 1 case really came as a case of rabies, means referred as a case of rabies. The patient had hydrophobia and aerophobia also. All other cases, subsequent questioning only brought out that the patient was suffering from rabies. So, and unfortunately, almost all of them had started vaccination. All were class 3 wounds, and none of them who died received immunoglobulin. So that has been my experience. That is class 3 wounds, not getting immunoglobulin, and then finally coming with rabies, where initially you are not even suspecting rabies. Subsequently, you come to know. Once a patient was planned to be extubated, the mother came and asked me, "Madam, today is my child's next dose of vaccine. So can I take the vaccine today?" And that is how we thought of rabies for that baby. So those kind of things can happen. So class 3 wound, definitely go ahead and give immunoglobulin.
If patient is taken IDRV 1 year before, but after 1 year they get exposure. What is the regimen, madam?
No, if you have taken IDRB, after 1 year they get a re-exposure, you just need to take a single dose on day 0 and day 3. So that is even if it is IDRB or IMRV, whichever route you have taken, re-exposure, you need to take only 2 doses, that is 0 and 3. No immunoglobulin is needed there.
When switching from IMRV to IDRV, and if they already took 0-3 doses, then can we give day 7 and 28?
No, you are shifting here to IM, so you would have to go for day 7, 14 and 28. Yeah. But this I again emphasize, whatever I said is off record because shifting is not recommended by WHO.
Then bird class, we already told. Boar attack, we didn't discuss. Somebody is asking.
Boar, I think somewhere. Okay, boar attack with its tusk. So I feel that should be unlikely to be a rabies thing because the tusk, the saliva cannot come to the this thing. So that looks like an unlikely source of a rabies.
Okay, duck and hen already we discussed. What about killed vaccines, madam?
Killed vaccines and anti-rabies vaccine, is it so? Or
yes, anti-rabies killed vaccines.
I don't know, because the question is written only as killed vaccine. I think, is it, if it is interaction with killed vaccine, rabies does not interact either with killed vaccine or live vaccines. It's only the immunoglobulin which may have an effect on the live vaccine. But here, whenever you are thinking about rabies, don't think about anything else. Just think about rabies and follow the rabies prophylaxis protocol. You don't have to think about anything. You have to follow the protocol.
And regarding the pregnancy, we had a good discussion. Should we give the immunoglobulin again?
If needed, yes.
If got pricked from a needle which was used to give vaccine to cattle, does this need to get a prophylaxis?
No, because here probably you're giving the vaccine to an asymptomatic cattle, right? So you are not going to get a rabies. Only if the cattle is symptomatic, you're thinking that way.
Needle prick with needle used to give immunoglobulin to fresh dog bite wound. What should that be done? That is again biomedical way.
Needle used to give immunoglobulin to fresh dog bite wound. That would be a very, very precarious answer to give. Because thankfully it is immunoglobulin, so it would have neutralized the virus which would have touched the tip. That's all I can say. But that's very difficult to say.
But that is anyway in biomedical waste management protocol. We are anyway not touching the.
It should
needle,
not be,
right?
but it can happen.
Oh, if previously taken IDRB, we need 2 doses only. But till what period? Like how much years back? If IDRB taken, we can use this guideline.
That's a good question because earlier there used to be recommendations 3 years, 5 years, and all. But now the WHO says that irrespective of the interval, whenever you are repeating the doses, immediately the antibodies have found to be increasing. But there is no time interval. But I would say that, say, after 5 or 6 years, you're having a category 3 wound, you may go for a full schedule. But the recommendation is irrespective of the interval since the last IDRB. If you are currently not immunosuppressed, you are a healthy person, you need to take only 0 and 3 because booster doses act very well. That is, we have learned all, like even for tetanus, after 10 years, you're taking 1 booster every 10 years and still you are getting protected. So same thing applies to the rabies vaccine also. So the interval is not important.
Ma'am, can you please once again what we are supposed to do if a patient miss one?
Okay, that's a good question. Okay, that I would definitely explain once again. What I said that whenever you are missing a particular dose, there is no need for you to restart the whole vaccination. You just think that the patient has come on the particular day and start from where missed. That means you were supposed to give the vaccine on 0, 3, 7, and 28. The patient took the vaccine on day 0. The patient came for the vaccine on day 3. But the patient did not come on day 7. The patient came 2 weeks later. So that day you are giving a vaccine and you are considering that vaccine as the day 7 vaccine. So 3 weeks later, you will give the day 28 vaccine. So you're just shifting the schedule, Mumbota. So start from where stopped. No need to restart. That's the message.
If rabies vaccine is taken in a 1.5-year-old child, how long should we wait before we get DPT booster? That is
here
also
because here you don't have to be bothered because both are killed vaccines. You can go ahead and give DPT. Interval is not important. If it was a live vaccine, you would have, but rabies vaccine is a killed vaccine, so you don't have to bother. You can take the booster anytime.
Can anyone get rabies during?
That is one way, but I would always say that whenever you're giving a rabies vaccine, complete the rabies vaccine schedule and then give a other vaccine, because you don't want the side effects to overlap and you'd want to exactly know which vaccine is causing what side effects. So always complete the rabies vaccine schedule and then go for the DPT booster.
Madam, can anyone get rabies during sex as sperm and vaginal secretion
it's
is?
possible. It's possible.
A clarification, does re-exposure after 1 to 10 days of starting first dose of vaccine require repeating the schedule?
Okay, I think the thing I said. So if you have already started a vaccination schedule, just continue with the vaccination schedule. You don't have to change anything because you have had a re-exposure in between. Now, if the child, that is, if you have given the first dose and you have already reached day 7 of your vaccination schedule, then you cannot give immunoglobulin. Beyond day 7, please do not give immunoglobulin. Once you have started your vaccination schedule, and then if you give an immunoglobulin after day 7, you are interfering with the vaccine's ability to produce the antibody. That should be very, very clear. Because whenever you are giving an antibody, the antibody is aimed, the immunoglobulin is aimed to protect you only for the first 7 days. If you start giving antibodies after the 7 days, that is the time when your vaccine should have made your body produce the antibody, there would be interference. The time limit of first 7 days for immunoglobulin.
Is it applicable to rabies monoclonal antibody also?
Yes, definitely. Because when the rabies monoclonal antibody came, one of the main contention was this: will the monoclonal antibody interfere with the vaccine's ability to produce antibodies? Thankfully, it didn't interfere. So we cannot give it beyond day 7. Because in case you'll end up giving beyond day 7, you have to think it is a new schedule. You cannot play around with it.
But here, one thing you have to be in mind that please use sensitization to the patient and the bystander, because they will make problems. So you have to sensitize the patient or the bystander regarding this. Otherwise, they will say that we have denied the treatment and all. It happened. That's why I am telling.
There was a cat 3 exposure. And HRIG along with day 0 doses given. And on day 3, the patient came again with another cat 3 exposure. Does the ERIG has to be given again, or you just continue with the pre-earlier dose?
Okay. That's a very difficult question to ask, because as I already said, in this case, if it is category 3 bite, and if you have given the immunoglobulin complete in the local area and also given in the IM area, it should usually be effective, because we already said that once you are giving an immunoglobulin, the half-life is close to 3 weeks. So you don't have to repeat the immunoglobulin. So what if you repeat the immunoglobulin? That is a question, right? So if you repeat the immunoglobulin, you are increasing the passively administered antibody content. And when you say 40 IU per kg, or when you say 20 IU per kg for human rabies immunoglobulin, it is the maximum dose. So imagine for the first bite, if you had given only 10 IU per kg, you can definitely give the rest in the next bite. But for the first bite itself, you had given 20 IU per kg, then you don't have to repeat it, because it will interfere with the vaccine response.
Okay.
That question is a very tricky one, because local.
It happened, man, actually.
Very important. It's a
very. That's why, yeah. The
The
situation happened to one of my colleagues.
But it has these. It has a double-edged weapon. In fact, it's a double-edged weapon. But ensure that the 20 IU was given. If it was not given, you can definitely give this time.
Okay, ma'am.
Should we repeat ARS for a new class 3 wound which have given, they gave past history of immunoglobulin injection?
I think the same question we answered.
Same question we answered. If a person who takes care of cow and cow have died of rabies due to bite of a dog, should vaccine and immunoglobulin be given?
The person definitely needs a vaccination. There is no doubt about it. And immunoglobulin also, if the hands or anywhere he had an injury, it would be better to give. Otherwise,
and what about the persons who took the milk?
No vaccination. No vaccination.
if patient misses dose until how much days of delay we need to restart the schedule, like if come to day 3 or weeks, 3 or 4 weeks?
Well, I think 3 or 4 weeks, that is okay. You can just continue with the same schedule. No problem with that. Remember that whenever you are giving a vaccine, I'm not talking about only a rabies vaccine, all other vaccines also, you always have a memory cell. And in fact, the longer the interval between the doses, better is the immunological response. But you will get a proper, complete immunological response only after you have completed the schedule. So that is the reason why we say complete the schedule. Although the antibody titer is not going to come down because you have increased the interval between the doses. The longer the interval, the better is the antibody response. So don't be hesitate. Don't be worried that somebody has come late, so the vaccine will be ineffective. No, the vaccine will produce a higher antibody titer.
Even if the schedule was taken with break, does it does it give 3 months full immunity? Yes, madam already told.
Yes, for 3 months you don't have to, because the WHO clearly says that if you have completed, if the patient misses dose, till how much days or delay we need not restart. No, there is no need not, right? Misses dose means
Yes.
you have to you have to complete the schedule, but no restarting. Restart is not the word. You complete the schedule.
Whether there is any chance of vertical transmission of this rabies?
Not reported.
Not reported yet.
Yeah, not reported yet.
If in a scratch and patient says blood came, is it considered as category 3?
Yes, definitely.
Ma'am, have you seen any kind of allergic reaction after IDRV in children?
No, IDRV in adults itself, we have seen allergic reactions, but that is okay. Milder allergic reactions at the site of injection, a little bit of urticaria has definitely been seen, but that is okay, I would say.
If a dog owner approaches for re-exposure prophylaxis multiple times and that too frequently, every time at an interval beyond 3 months, is there any restriction or any ceiling?
Okay, in fact, there is no restriction as such, but you can interpolate from the other way. That is, what is the recommendation for dog handlers or people working in the anti-rabies rabies laboratory? There, the recommendation is every 6 months. If there's a facility for looking at you can give boosters every 6 months, or you can check for titers and decide. So that would be difficult practically, but that is what the recommendation says.
I think that's all about the questions in the chat, but if anybody is having still questions, you can ask directly. The platform is open.
I request Dr. Anil to say the facilities where this IDRV and this
vaccine facilities are available.
ARV is available if possible.
In our state, as part of the NRCP program, we have IDRV in all medical colleges, general hospital, district hospitals, taluk hospitals, community health centers, and selected family health centers and private health centers in EDG, etc. And as far as this immunoglobulin is concerned, we have immunoglobulin in district hospitals, general hospitals, and medical colleges only. We don't have immunoglobulin in taluk hospitals. And it is free also.
Thank you, sir.
Dr. Shija, there are some malpractices also, especially in some rural areas. That is putting some turmeric or coffee powder in the wound, and also that sorts of practices are still there.
Yeah, secondary
Is
infection
advisable?
have to take. Yeah, definitely not recommended. Any kind of local medications are not recommended, because you would be adding on to another infection there.
Yeah. This also you should communicate to the public.
Any questions? Or if it is, if no, there is no question, we'll request Anil sir.
One more final question. Is there any case in the history? I heard one case escaped from rabies. I don't know whether
is there any case of survival from rabies?
Survival,
There are around six reported cases of rabies survival, but most of them have a neurological sequelae also. The photo of the child that I showed, in fact, the child had survived for 30 days on an induced coma regime of Milwaukee. But finally, we gave up sort of a situation because there was no improvement, nothing, complete vegetative state the child was. So that was a case of, in fact, the other one, the dumb rabies, the paralytic rabies. So there are reports of survival, almost 6 cases survival are there, but I don't think we should be highlighting that.
Yeah,
taken as
it is 100% safe.
yeah.
The facilities where this testing can be done, no? That also, if possible, they need to know. I think the State Public Health Lab, Trivandrum, has the facility to test this antibodies.
Sample testing.
Yeah, sample testing.
Sample testing, in fact, we sent to the Palod, the Rabies Institute for Research. There we send. And there they check the samples from the corneal imprint they take saliva, and they also receive CSF. So all our cases, all the 4 cases that I said, they were confirmed from there itself.